The human body is indeed and truly a marvel of creation. The circulatory system is the life-sustaining organ of the body. If we were to take all of the arteries, veins, and capillaries and stretch them out into one line, the length of that line would be 60,000 miles in a child and 100,000 miles in adults. This would be length enough to circle the equator 4 times. However, it only takes about 60 seconds to make a complete circuit of the circulatory system, leaving the ventricle and returning to the atrium. In essence, and very simplistically then, the circulatory system is a series of connecting tubes that allows the blood to flow as a liquid. The total volume of blood in an adult is 5 liters, and the heart pumps a miraculous 4,000 gallons of blood per day. In just one drop of blood, there are 10,000 white blood cells, 250,000 platelets, 5 million red blood cells, and the other half of the drop is plasma. When we use a vascular access device, it also can be termed fairly simplistic. We are placing a tube into a tubular system. However, when we do that, we are violating the structure and function and normal anatomy of the vascular system. And as Virchow identified in the 1800s, we create venous stasis, vessel injury, and in the face of hypercoagulability, increased thrombogenicity. Now in the 1800s, Virchow didn't have vascular access devices around, but we could make a quadrant of this and say that the device itself is indeed thrombogenic. And in addition to that, we have one other problem. We also create a portal of entry for microorganisms. So that leaves us, while we are using vascular access devices or life-saving and supporting intravenous therapy, it is still a rose with potentially many thorns. And the 2 major complications that can result from the use of these devices are, of course, as you all know, infection and thrombosis. However, there's several other secondary types of complications that add to the complexity of this. Indeed, malposition and occlusion. Malposition can result in thrombosis and also occlusion. But when we have malposition and thrombosis, we have a whole myriad of other secondary, very serious complications, and who's looking and who's counting. We also can result in occlusion from vascular thrombosis. And occlusion can result in infection, and thrombosis can result in infection, and then infection in and of itself can create thrombosis. How many devices do we use in the United States? Well, here's just a very quick breakdown. Arterial catheters, 6 million per year. Short-term percutaneous devices, catheters, 4 million. Long-term surgically implanted, less than you would think, at 0.3 million. And PICCs, 2 million and climbing rapidly every day. Is it not interesting that we use equal number of devices to access the arterial system where the same complications absolutely apply, but yet no one's looking or counting those either? Now, originally, we thought that the great benefit of the PICCs was to reduce the risk of infection, and indeed, early on, it did. But things seem to be changing, and there's a very somewhat disheartening trend in the literature. This is a article that I can't see the citation is on this slide, but I can't see it. I believe it's Provic. And this was a systematic review of 12 studies that compared complication rates of PICCs and central venous catheters. Now, they looked at 4 different complications, starting with malposition. You can see the odds ratios here. You have 3.8 times more risk of a malposition with a PICC catheter than a central venous catheter. In relation to catheter dysfunction, you have 6 times more chance of a catheter dysfunction with a PICC than a CVC. Also in this study, in the meta-analysis, he found that thrombophlebitis, a 5.8 greater chance of having with a PICC than with a central line, all 3 of these being statistically significant. When they looked at infection, and I must say some of these studies they did point out as limitations that they weren't all using the same definitions and criteria. However, the numbers turned out that there was no difference between catheter-associated infection in PICCs and central venous catheters. Now, again, here is the citation, and you can see that this study was just published in the early part of 2012. So this is relatively new data. And then they combined all of the complication rates and found that you have 2 times more chance of a complication with a PICC catheter than with a CVC. So, should we stop using them? The trend is not going in the right direction. I would say no. Should we be concerned? I would say yes, indeed, about both infection and thrombosis. If we are going to, well, I'm going to just say, as nurses, the PICC catheter has become definitely a procedure and in the care and hands in the domain of nursing. And we have got to take a very serious look at this kind of data and this kind of information. And we need to begin to take more serious attention to applying and adhering to pathogenesis-based practices. We need to utilize practices such as patient assessment for the right device for the right therapy. We need to assure proper catheter tip position. We need to use shorter sheaths and shorter dilators to reduce vessel injury. We need to use scrubbing devices for access site and catheter hub disinfection. And we also need to rethink the use of tapered PICCs. And lastly, we've got to begin to better utilize and assess new technologies that will help reduce these complications. And with that, we're going to talk today about some new breakthrough in technology in vascular access that hopefully will have a big impact in the reduction of catheter-related infection and thrombosis. Now, my disclosure was presented earlier, but as you can see, I work with many industry folks, and it was many years ago that I really discovered that we were not going to be able to solve the problem of infection, particularly in relation to biofilm, and some of the other complications without the use of good, safe, and efficient technology. And it was with that that I devoted my career to working with industry to be able to set up good programs of research and be able to test devices so that, in essence, when you choose them, we are improving outcomes for patient care. So I'm going to address both the complications of infection and thrombosis today. Let's begin with infection. We said that catheters are, simplistically, tubes, and they also create a portal of entry into the circulatory system. So where are the sources for colonization? There's an inside of the tube and there's the outside of the tube. The extraluminal source of bacteria that colonize the external surface is at the skin insertion site. And this is the primary source of infection in short-term catheters. The intraluminal side of the catheter is an important source of colonization for all types of catheters, but primarily occur after about 5 days. Well, how can I say that? And also, indeed, which surface is the highest risk for infection, particularly when we're talking about PICCs and the longer-term dwell times? Well, finally, we have some data that I think very clearly identifies the differences in the source of infection. This was a study done by Jim Davis and the Pennsylvania Patient Safety Advisory Committee. They did this study to determine whether an institution should focus resources on a specific phase of CVC life to prevent CRBSI. In other words, we're currently applying a lot of resources, a lot of surveillance, and a lot of attention to insertion technique. But is this where the primary source of infection occurs, or is it somewhere else? So to determine this, they analyzed the NHSN database for the state of Pennsylvania for the year 2010 to determine the date of infection event from the time of insertion. In their data analysis, they found there were 653 catheter-associated bloodstream infections. 71% of these infections occurred after day 5. As you see in the graph, this represents 98% of the infections that occurred that year. And graphically, each infection is plotted out to 60 days. So here, at the first arrow, we see that the mean time to infection was 14 days. And that the median time was 10 days, meaning that half of the infections occurred after 10 days and half before 10 days. But the mode is 5 days, and that is the day at which most of the infections occur. And we can, in general terms, indicate that those infections that occurred 5 days or less were primarily insertion-oriented, and those after 5 days were primarily intraluminal. So the conclusion was that this data implicates maintenance as the phase in which CLABSI is most likely developed. So how does the intraluminal surface become colonized if this is our primary source? Well, that's the hard part of all of this, because with the extraluminal, we know that the primary source is the insertion site. So there are a lot of good technologies and a lot of interventions we can apply there. But with the intraluminal, we have so many different portals of entry, and the use of these is quite large on a daily scale. We have stopcock hubs, we have injection ports, we have needleless connectors, and the catheter hub itself, all of which are entry points. We tend to focus on the needleless connectors, and indeed we should, but we tend to forget the other ones, and they are just as high a risk as the connectors themselves. So how does this happen? Well, it's pretty simple. If there are bacteria, and there are, on these access sites, and the nurse fails or physician fails to disinfect and remove these bacteria from the access sites, when we apply a syringe or an administration tubing, we literally flush those bacteria into the connector, into the hub, and into the catheter, and we inject those immediately into the patient. However, even during infusion, or if we disconnect the syringe or administration tubing, and bacteria are left anywhere within this system, they will attach to the internal lumen surface of these devices. They will then stick to the surface, form a biofilm, and these biofilms then will produce large numbers of shed planktonic cells. And then when we re-access or inject either by syringe or administration tubing, we inject those newly created bacteria into the patient's bloodstream. So we have two problems. Now this is a picture in real time of biofilm. And biofilm, when they attach to surfaces, join together to make or produce an extrapolymer saccharide. And you can see it's a very slimy type of material. They embed themselves in this matrix and become protected against antimicrobials and antibiotics. They are very tenacious and they are very difficult to remove. Now, I want you to think what device this is. Where are you seeing this biofilm? It's important that you get a mental picture of this, because this is what biofilm looks like on the extraluminal surface, intraluminal surface, on the needleless connectors and the access sites. Well, if you haven't guessed by now, this is the device where you are observing this biofilm. Biofilm is everywhere. It's in the environment, it's on the bedside stands, it's on the TV controls, and it's on our medical devices. So this is what we're trying to prevent. And the only way we will prevent the formation of that biofilm is to not allow access to the system for bacteria to touch these surfaces. So what does the evidence tell us we need to do in relation to protection with catheters? And this is the 2011 CDC guidelines and their Category 1A statement on antimicrobial and antiseptic impregnated catheters. They say recommend to use a chlorhexidine, sulfur sulfadiazine, or minocycline rifampin impregnated CVC in patients whose catheter is expected to remain in place greater than 5 days, if after successful implementation of a comprehensive strategy to reduce the rates and they're not decreasing. Now you notice that the implementation strategy, in essence, if they're going to be in not more than 5 days, would be correct, because these are all focused on the prevention of extraluminal infection. However, if they're going to be in greater than 5 days, then we need to protect both the extraluminal and the intraluminal surface. So this doesn't talk about PICS, but at the time these were written, antimicrobial PICS were not in the picture. However, we do have antimicrobial and antibiotic PICS available today. In relation to the antibiotic-coated PIC, it is both internal and external coated. However, one of the big problems with these devices is that they are not coated on the intraluminal surface of the little extension tubing and the catheter hub. This is a primary source of biofilm formation, as it is directly at the access portal. So we now have a new device on the market, which is a chlorhexidine-coated PIC catheter. This device is coated on the external lumen surface, as well as intraluminal. Also includes coating of the extension tubing as well as the catheter hub. Now, by Teleflex Medical to design, conduct, and evaluate the efficacy of this antimicrobial coating on the reduction of extraluminal and intraluminal catheter surface colonization. I put together a research team of experts. Dr. Gunther is an independent consultant, formerly a professor at the Animal Resource Labs and Department of Surgery at the University of California, Davis. Dr. James and Dr. Pulcini are in the Medical Biofilm Laboratory at the Center for Biofilm Engineering. Dr. Parker is the statistician from the center, and Dr. Silva and Dr. Breznak are the veterinarians and study directors of these projects, and Laura Bickle was the technician who did all of the colonization work at the center. So they are the investigators who make the research team for all the studies you're going to see today. The purpose of the studies was to determine the effect of the chlorhexidine coating on the reduction of colonization of both the extra and intraluminal catheter surfaces. This required 2 independent studies because it is not prudent or not possible, basically, to study both surfaces at the same time. So we're going to look at the intraluminal study first. And of course, here's our study question, wanting to know whether there's a difference between the coated and the uncoated in colonization. The study protocol, and as all of these studies, were approved by the IACOC, which is the approval board, the same as the IRB, except in the animal kingdom. The study design was experimental, and the duration was 8 days. Very briefly on the procedure, the sheep were randomized to the catheter group. They were intubated and put under anesthesia. The preoperative skin cleansing was done with a rigorous chlorhexidine skin scrub. It was followed after the sheep was taken to the operating room with a chlorhexidine and alcohol skin prep. Maximum sterile barrier was utilized in the OR. The catheter was inserted by the modified Seldinger technique. Catheter tip location was confirmed by fluoroscopy in the distal superior vena cava. And on day 1, Staph aureus 10 to the third per mil inoculum was instilled in the catheter at fill volume. None was injected into the sheath. It was left there for 3 hours and then was withdrawn. Post-insertion, and then beginning on day 2 and throughout the duration of the study, the sheep was infused with a daily infusion of lactated ringers, 50 mils per hour times 8 hours. Prior to entry of the line, a scrubbing device was used before each connector entry. Following the infusion, the catheter was flushed with saline and heparin 100 units per mil. The insertion site care was done every 3 days with chlorhexidine and alcohol skin prep, and the application of a chlorhexidine foam disc followed by vet wrap. These procedures were done the same as we would be following in the patient care area. I was very particular about protecting the extraluminal surface so as to not interfere with the evaluation of the intraluminal colonization. For catheter assessment, let's take a look at what we found. We did catheter blood cultures, and here you see the results of the catheter blood cultures trying to determine colonization and biofilm formation on the intraluminal surface. You see the results of the day 1 inoculation. I would expect that there would be some attachment to the catheter surface, but very interestingly, you see on day 2 and every day thereafter, the antimicrobial surface eliminated all of the attached bacteria. Compare this then to the catheter blood cultures in the control group. And as you can see, we went from a 10 to the 2, remember this was 10 to the third per mil, we went through from an attachment rate of 10 to the 2 almost immediately to a 10 to the 5th, which was maintained over the 8 days. That is an incredible growth of biofilm and shows you the ability of attached bacteria to produce other cells. As far as their temperatures, that was the other clinical assessment, and our decision rule was if they had a temperature of 105 degrees for 2 days in a row, they were determined to be clinically septic and were removed from the study. Now here you see in the treatment group, the temperatures were as much as 104 degrees. But this is the high normal temperature for the sheep. So all of the treatment sheep were afebrile for the duration of the study. Compare that then to the control group, where you see that after the biofilm formation increased, so did the temperatures. Now, as far as what did we find in relation to biofilm growth, here, when at the end of the study, the sheep were euthanized and the catheters were pulled out, removed, and shipped to the Center for Biofilm Engineering for biofilm analysis. So the catheters were sectioned and each area was studied. So we have colonization rates. You see the catheter hub. This was not statistically significant at 0.07, but take a look at the numbers. We went from 2 logs to less than 1 log, which indeed was protective. The same, looking at the biofilm in the extension tubing, there was growth in the control group, but there was no growth in the extension tubing, in the internal lumen catheter, at the vessel, at the catheter section at the entry to the vessel, and there was no growth in the tip segment either. These did turn out to be statistically significant. But remember, we're only dealing with n's of 3, so that's quite remarkable that there was statistical significance. This study was presented by poster presentation at the SHAKE conference last year, and you will have access to this study to look further at the methodologies and the results. Now, what about the extraluminal surface? How does it become colonized? Well, one of the things I think we tend to forget or not to think about in our pathogenesis-based interventions is that, that there are 3 tissue spaces that are crossed when we insert a vascular device of any type. First, we go through the skin, then we go through the subcutaneous space, and then on into the intravascular space. All three of these are important in the pathogenesis of infection. Now, let's see how this happens. Let's do a venipuncture together. And you'll notice that there are bacteria on the skin, and we're about to do the venipuncture. The number of bacteria that are on the skin will be determined by you, and it will be determined by how well you do or you do not do the preoperative skin prep. This is an absolute critical step in the prevention and the first line step of prevention of extraluminal colonization. So with a rigorous skin cleansing as well as application of the antiseptic, we can pretty much reduce the number of organisms. However, that is on the surface. However, we do have resident bacteria in these deeper layers of the skin as well as the hair follicles and sebaceous glands. So we can remove pretty much all of them on the surface, but there are underlying bacteria. Okay, so let's begin. We do the venipuncture. And when the venipuncture is done, you will be taking bacteria into the subcutaneous space and into the vascular system. How many go in with this process? Again, that's up to how many you've left on the surface of the skin. We then insert the guide wire. We remove the needle. And then we place the dilator and tear away sheath. And with each one of these insertions, we are again injecting, if you will, bacteria into these tissue spaces. We then remove the guide wire. We then remove the dilator. And then I want you to think for one moment, to this point, how many times have you touched the skin in this process? I would say quite a few, okay? And that's a part of the procedure. But just know, again, how importantly that preoperative skin prep was, because now your gloves are contaminated. And here is where the next step in the procedure, where you pick up the tip of the catheter and you begin to insert it. And with each step of passing the catheter, you're again touching the extraluminal surface. So we take the catheter in then with any number of organisms. After insertion, then the organisms will rebound from the deeper surface layers, as well as any organisms that were remaining on the skin will again form colonization. Looking at the different tissue spaces, again, you've now placed some level of bacteria into the subcutaneous space. Those bacteria will do one of two things. They will either attach to the surface of the catheter, or they will be attached to the tissue in the subcutaneous space. They also can form a biofilm in the tissue or on the catheter. And here you see a colorized photo of biofilm in a wound, and this is a wound. We also have bacteria that have attached to the surface of the catheter, and they will begin their process of biofilm formation. And here in this SEM photo of the extraluminal surface, you see the beginning steps of attachment and adhesion of bacteria on the surface. So, our study question then in the second half of the 2010 study was to determine the efficacy of the extraluminal surface. Again, it was approved by the IACOG. It was an experimental design, and the study duration was for 10 days. Again, this poster and the results of this study were presented at the SHEA conference last year, and you would have this poster available to you so that you can read more in depth about the methodology and the results. So we're going to look at a few. But now let's understand how we did the methods for this study. In this case, we are going to be protective of the intraluminal surface. And I'm also testing the efficacy and the ability of this chlorhexidine acetate coating to prevent colonization of the catheter. So while we were very protective of the skin and the extraluminal surface in the last study, this time I'm not going to give the catheter any help. There will be no chlorhexidine, no antiseptic used, because I am testing the efficacy of the coating. The sheep were randomized to catheter group. They were again intubated and put under anesthesia. This time the preoperative skin cleansing is being done with soap and water scrub, and then we applied alcohol and allowed it to completely dry. I want to remove all of the normal flora from the sheep's skin because we are now going to inoculate the skin at the insertion site. We did this with Staphylococcus aureus 10 to the 6th and applied it over a 2 centimeter squared area. Why did I choose 10 to the 6th? Well, here you can see a culture plate of a non-cleansed area in the subclavicular space. The normal colonization rate in a male on the chest and the neck is 10 to the 6th, and in women about 10 to the 5th. So I was using the normal flora rate of the human. They were randomized to, in this one they were placed in each jugular. Catheter insertion again was done by the modified Seldinger technique. The catheter was flushed with heparin 100 units per mil through a neutral needleless connector, and it was never accessed again for the duration of the study. Catheter was secured in place, and this time a gauze dressing is applied with no antiseptic and vet wrap. The site care was done with saline cleansing on Mondays and Fridays. What did we find? From watching the clinical assessment of the sheep, again we had the decision rule of 105 degrees times 2 days. Here is the temperature of all of the sheep in the study, and again seeing that all of them were afebrile for the duration. Compare this then to the temperatures of the control sheep. And again, we had 3 of them were determined to be septic, as you can see from the yellow stars, and they had to be removed from the study. Notice that they were removed day 5, 6, and 7. So let's take a look at the vessels themselves. And here, when the animal was euthanized, then we did an en-bloc dissection in which we took the entire catheter within the tissue, including the skin, the sub-Q space, as well as the vessel all of the way to the right atrium. Here you can see the catheter within the vessel, and it almost looks like it's outside, but know that the vein wall is transparent and you can see through. So we removed the skin, and we also did cultures of the skin throughout the study as well. Removing the skin, you now see the subcutaneous tissue, and you see that it is somewhat of a pearly white material. This is actually a collection over time of fibrin, granulation tissue, and collagen and connective tissue. This is normal in appearance. We removed the subcutaneous tissue, and now you can see the entry point of the catheter into the blood vessel. And in excising or opening the entire length of the vein so that we could observe both the catheter surface as well as the vein wall, you can see, very interestingly, that there is no fibrin sheath and that there is no thrombus within the vessel itself. This was quite peculiar. Compare this then to the control catheters. And here we see a dramatically different picture. This vessel is very necrotic, very swollen, and we see a high level of cellulitis. It was also very difficult to identify the vein tissue itself. Removing the skin, we see the subcutaneous tissue. Instead of that pearly white connective tissue, we see very highly infected tissue. At the vein entry, then we immediately past the vessel entry, we see a lot of thrombotic material. And in incising the vein open, now we see both a lot of fibrin sheath formation as well as thrombus formation in the vein itself, and very extensive necrotic tissue and cellulitis. So compare then the control catheter with a high level of infection to the treatment catheter. From the biofilm analysis, we analyzed both the tissues at the skin level and also at the subcutaneous level, and you can see that there was a significant reduction in biofilm formation in the tissue spaces. On the catheter surface, again, we see a dramatic reduction both at the vein entry and the catheter tip position on the catheter surface itself. Now, one thing that we noticed in the treatment catheters, unlike what I have seen repeatedly in all of the sheep work that I've done over quite a few years, I've always observed a fibrin sheath formation, even in the absence of infection. But in these catheters, it was an incidental finding that there were no fibrin sheaths or very limited development of fibrin sheaths on the chlorhexidine catheter. And it really, posed the question, is it possible that the chlorhexidine coating could have both antimicrobial and antithrombogenic properties? We'll come back to that. How does catheter-related thrombosis increase the risk of infection? Well, we know that when we place a catheter into the bloodstream, that within milliseconds, plasma proteins will condition the catheter surface. And the conditioning is done, but remember, in 1 drop of blood, half of it was plasma. Well, within that plasma are proteins, and these proteins will adhere and stick to the catheter surface. Within minutes, then, we'll have platelet and white blood cell response and will be adherent to the fibrin and proteins in the conditioning layer. These platelets then will release thrombogenics, and the thrombogenesis pathway begins. Also, in the subcutaneous space, within minutes to hours, we have a nonspecific inflammatory response because we have traumatized and injured these tissues. So we will have mast cell release, capillary dilatation, the invasion of fibroblastic and granulation tissue, and eventually in that healing end process of the healing, we will have the collagen encapsulation that we observed. And here you see that. This is not from the current study, but another study where I have dissected or done an end block dissection, removed the entire length of the catheter. You see the skin here on the left, and the catheter is still in place. But directly underneath the skin, we see this lengthy subcutaneous space of which we have literally a fibrin or a collagen sheath around the catheter. This sheath is continuous and contiguous with the fibrin sheath within the vessel. This has all kinds of implications. First, as you see in this picture, you see that nice collagenous ring or fibrinous ring around the catheter in the subcu space. But you also see a space in between the catheter and the collagenous ring. It also looks very liquidy. Again, you have some edema, and this will allow for the dispersion of bacteria from the surface of the skin throughout this column. And that column, again, is an open space all the way through the subcu space and the fibrin sheath. It's literally one tube. The other implication here of a very serious nature is when we remove catheters, the potential for air embolism through this tube. Now, within weeks and days, we're back to the intravascular space. You have red blood cell attachment and the potential for pericatheter thrombosis. Here is a very good picture of a cross-section of a catheter removed from the superior vena cava. And in the center, you see the collagenous fibrinous ring, or that conditioning layer that we identified. And then in this case, there was a very large pericatheter thrombosis that developed. Now, within days, remember this catheter went in with some bacteria, both in the subcu space as well as attached to the catheter surface. Whatever bacteria were there will build a biofilm. And within about 5 days, and here you see bacteria attached to the extraluminal surface of the catheter that are embedded within this proteinaceous material. These will then mature, and also note, as in this picture, this is a biofilm developed on the external lumen of a catheter that is not embedded within fibrin. They don't really need the protein to attach. They will attach to pretty much any surface. So this is a biofilm, large colony, not involved with fibrin. So at about 5 days or less, these biofilm will produce and release large numbers of cells, and these can be floated away into the bloodstream. Also, for the fibrin sheath, what we really need to understand as well is that early on, what we talked about was really a cellular response to the presence of the catheter. But over time, and particularly after about the first 2 weeks, we will see a transformation of this cellular type of material into a non-cellular material. And it will be encapsulated with smooth muscles and endothelial cells. The smooth muscle cells come from the vein wall at the insertion site. They will cover the fibrin sheath and then turn into a collagenous type material. This is important to know because if you have thrombosis or if you have occlusion due to these fibrin sheaths, the use of a thrombolytic agent will not be effective because you're no longer dealing with fibrin. Now, the question becomes, can this be prevented? Can we stop the fibrin sheath and thrombosis formation? Because of the incidental and very interesting findings from the prior work, we set out to study that question. And this study was done in 2 studies in the summer of 2011. And the purpose was to determine the effect of a chlorhexidine coating on the reduction of catheter-associated thrombus, again done by the same research team. Study protocol was approved by the IACOC, the experimental design. We did 2 studies, 2 groups, one at 12 days and one at 31 days. I will only be able to cover and present to you some of the material from the 31 days today. We had 3 groups this time. We had a control on-coated catheter, we had a control predicate device with a biomimetic coating, and then we had the chlorhexidine acetate test catheter. There were 3 sheep in the control groups and 3 sheep in the treatment group. The outcome measures, we did again an en-bloc dissection at term. We measured the length and weight of the fibrin sheaths, and we also did histology to determine pathologic changes in the vein and the fibrin sheath. Here are the results. There was a significant, if you look at the control, and we consider the control or uncoated to be at 100% and compare the other 2 catheters to the control, you see that there was about a 50% reduction in fibrin sheath weight in the chlorhexidine coating with a somewhat dramatic increase, at least at 12 days, in the control 2 catheter. For fibrin sheath length, again, the trend was for a reduction of the length of the fibrin sheath in the chlorhexidine catheter and an increase in the predicate device. While these were not statistically significant, we did see a trend at reduction. Now, in order to look at the histology, we need to just kind of refresh ourselves on the anatomy and structure of the vein wall. Here in the center, we see the lining of endothelium. This is a 1-cell layer thick of endothelial cells, and it is the endothelial cells that have produced anticoagulant to keep the blood liquid. The next layer beneath the endothelium is the tunica media, and these are primarily smooth muscle cells. They are procoagulant in nature. And the outer layer of the vein wall is the tunica adventitia, which is loose fibrinous connective tissue. And then, unlike arteries in the veins, we have valves, and these are smooth muscle cells coated by endothelial cells. If we now look at a histological section, and I wanted to go over this because we're going to look now at different sections of the catheters controlled and tested. Here in the histological section, what you look for is, if you notice very closely, that the surface here is lined with a series of black dots. Those black dots are the nuclei of the endothelial layer. Underneath that, you see the tunica media, which is the rather narrow, reddened area of smooth muscle cells. And then underneath, we see the loose fibrinous and connective tissue of the tunica adventitia. Surrounding veins, then, is connective tissue and adipose tissue. And in this slide, this is normal histology. Now, one of the ways we could measure vessel injury in this study was histologically looking for what's called intimal hyperplasia. And intimal hyperplasia is the thickening of the tunica intima in response to injury. And in this case, the injury would be mechanical in nature, of the body of the catheter irritating and rubbing against the surface of the vein wall. And in this case, you see some rather severe intimal hyperplasia. As you note, the endothelium appears very rough and raised and irritated. We also saw damage enough to where there were round nodules protruding from the intima. And in the center here, you see this darkened red material is the result of the chronicity and transformation of these injured areas with mineralization, actually some calcification. So let's look then at the control catheter. This was at 31 days, and looking closer, you see the extent of somewhat segmented fibrin sheath formation. Looking closer then directly at the catheter insertion site, and now in this section, you see the catheter tract right at the venous insertion. In surrounding then, we see dense granulation tissue and fibroblastic tissue with lymphocytes and neutrophils. And again, this is the normal response to tissue injury. And of course, with the irritation, we see fibrin and hyperplastic endothelium. Looking at the cross sections then of the fibrin sheath, this is the proximal fibrin sheath, and it has several sections. And you can see that based on the surface of the catheter, the irregularity of the formation. We see amorphous fibrin and degenerative white blood cells and red cells, dense fibroblastic tissue, neutrophils. In the center, we see hyperplastic endothelium, and again, this grows out from the vessel wall to coat both the inside and the outside of the fibrin sheath. And within it, we can also see lymphocytes, plasma cells, and RBCs. All of these things of which we identified in the normal response. For the distal fibrin sheath, this one looks a bit different. Even if you notice in the picture that this is more bright red in color compared to the more dull and whitish appearance of the other ones. And that's evidenced here as a more acute formation with amorphous fibrin and attached white cells and red cells. At the tip, we see some pretty extensive multifocal intimal hyperplasia and endothelium and connective tissue cells that are trying to heal the injured areas. Now let's look at the test catheter. In this picture, this was one catheter in the all of the test catheters. There's nothing to report here because, as you can see, there is absolutely no fibrin sheath. There is a totally clean vessel wall, and all of the histology sections were perfectly normal. This was one of the three catheters. But let's look at another, because I don't want to leave the impression that they all look like that. The others did have some fibrin sheath, but they were very short. Now this one is interesting because, again, you see the chronicity and the transformation from cellular to non-cellular. And also you see the more acute formation, meaning that these sheaths and thrombosis can extend. If we look at the proximal fibrin sheath, again we see what we would expect, the fibroblastic tissue, the white cells, the red cells, but interestingly on the inside, just as in that nodule, over time the sheath became very dystrophic, and we see multifocal areas of mineralization or calcification. And that's why you see the coloration difference in the fibrin sheath. In the distal fibrin sheath, as we would expect, it's more red in color, so we see more fibrin layers and trapped red blood cells. We also see the outer layer being fibroblastic tissue. Again, all of this is coming from the vein wall to cover this up. And on the top portion of this picture, you can see a section of the sheath, that fibrin sheath that was actually attached to the vein wall. Now, looking at, from the histology and pathologist report, looking at the extent of the intimal hyperplasia, we can see that at the vein entry, there was probably very little vessel injury and mechanical damage done to the intima. But very interestingly, when we get to the midsection of the SVC, we see much more extensive intimal hyperplasia, meaning more trauma. But you can also see that it was more significant in the uncoated catheters as it was the test catheter. And then looking at the hyperplasia at the tip of the catheter, this was also very surprising because one would expect that the tip would have created more intimal damage. But as you see in the trends, the test catheter had, in general, less tissue damage than either of the control catheters. Now, how does thrombosis promote infection? And this is done by receptor ligand attachment of the bacteria to the proteinaceous material by ligands and receptors. Does infection promote thrombosis? Yes, this is a whole other chain of events, and it has to do with the effect of the bacteria and the endotoxins and initiating the thrombosis cascade, as well as the leukocyte activation, which creates procoagulant activity. So looking then at our last study in terms of trying to determine the effect of the chlorhexidine coating on the reduction of both thrombus in the presence of an infection. Again, we used the same model for 31 days with the 2 control groups and the treatment group. Outcome measures were very similar here with fibrin sheath length and microbiologic examination of the catheter surfaces and the pathologic changes by histology. The methodology was the same as we followed in the first study. This time we only placed 1 catheter randomly selected in each sheath, again with the 2 centimeter squared inoculation. We looked at temperatures, white blood counts, peripheral cultures, insertion site cultures, and block vein dissection, as well as the catheter segments and fibrin sheath. The first interesting result was that in the control group, all 3 of the sheath were determined to be septic within the first 7 days. In the second control group, 2 of the sheath made it to 7 days without infection, or with to 7 days, and 31 days for 1 animal, while all 4 sheep in the chlorhexidine group made the 31-day endpoint with no infection. As far as the fibrin sheath weight and length, again, you can see that there was a dramatic difference and a statistically significant difference for fibrin sheath formation of the chlorhexidine catheter compared to both controls, both for fibrin sheath weight as well as the length. Now let's look at the macroscopic and microscopic assessment. And here is the chlorhexidine test catheter at 31 days. Again, very similar to what we saw in the other studies, a very, very small fibrin sheath, about 1 centimeter in length. And at the insertion site, an interesting finding here was that in the subcutaneous section, we see the development of keratinized squamous epithelium, and this was consistent with ingrowth of the skin down into the subcutaneous tract. Over to the left here, we see the connective tissue and dense fibroblastic tissue, and also we see the beginning portion of the vein on the lower right, and this vein, we can see the lining of endothelium. So this really shows very pictorially how this sheath within the subcutaneous tissue is continuous with the fibrin sheath in the vessel. Looking at the vein wall was relatively not remarkable. We do see some intimal hyperplasia midway, and again at the tip of the vein, some mild hyperplasia. Here is the control group, the biomimetic coating at 7 days, and here we see something dramatically different, again like we did in the first study. But as the vessel is excised, you can see extensive fibrin sheath formation, thrombosis within the vessel, and severe cellulitis and infection in the tissues. Looking closer then, here's a close-up of that vessel, a lot of fibrin material. Histologically, in the subcutaneous tract, now we see a very different picture. And in all of these slides, you're going to see very diffuse transmural necrosis and necrotic inflammatory cell debris. At the vein at insertion, now we begin to see something even more remarkable. In the upper part, you see the black sections within the vein wall itself, and these sections are actually biofilm colonies. Again, we see diffuse transmural necrosis throughout the vein wall as well as the catheter tract. If we look at the vein tissue midway to the tip, the same kind of picture within the vessel wall itself. The transmural necrosis, we see loose fibrin in the lumen, and now we see a valve and the vein wall. But if you look very carefully, now those black dots are not endothelium. Those are actually biofilm colonies. To the bottom right, where we see all this inflamed tissue, we can see histologically adipose tissue that's necrotic with proteinaceous edema. This is cellulitis. Looking much closer then at that lining of the vessel wall, there are the biofilm colonies attached to the surface. Looking much closer, this is the intraluminal edge of the vein wall and the extensive biofilm formation. So that's actually some of the first photos and gives us of biofilm formation within thrombus as well as vein walls as well as fibrin sheath formation, and gives us a lot of knowledge now about the relationship between infection and thrombosis. How did that turn out from a microscopic evaluation and biofilm formation? We took the sections, the fibrin sheaths from these catheters, sent them to the Center for Biofilm Engineering, and had them analyzed for biofilm. As you can see on the chlorhexidine catheter in the fibrin sheath, there were less than 10, there were 2.5 microorganisms in those small, less than 1 centimeter sheaths. Comparing that to both control groups, where there was massive amount of biofilm and numbers of cells at 1.4 times 10 to the 9th, that is a 1 with 9 zeros, and in the control 2, 1.2 times 10 to the 7th. So these were massively developed with biofilm. Then looking at the catheter sections, if we were to combine the biofilm bioburden on the catheter surface itself, in the chlorhexidine catheter, that 10 to the minus 1 is actually a 0. When you do statistical analyses, if you have a 0, you have to put a number in. But in reality, there was no growth and no cells, bacteria found on the catheter surfaces, comparing again to the control 1 and 2 group, where 10 to the 4th was observed. So in summary then, We look at the effects of both the antimicrobial and antithrombogenic effects of the chlorhexidine test catheter compared to the uncoated control and compared to the predicate device. Now, one thing, these studies were done in the jugular vein, and the reason why they were done there was to eliminate the many variables and many intervening variables that that occur when catheters are placed in the arm. And in this case, we were asked to evaluate the effects of the surface coating. And so to remove those variables, we placed them all in a larger vein that would not have the intervening variables. We did do a PIC study with these catheters in the leg, and this data is going to be presented at the SHEA conference. So with that, at least in conclusion, for what we saw in these 4 and 5 studies, is that the chlorhexidine PIC is effective as an antimicrobial and antithrombogenic catheter surface. And indeed, I believe that this is a breakthrough in technology that may, to be seen, to improve outcomes with PIC catheter use. So with that, that is the end of my presentation.